Alright. Hi, my name's Joseph Katta, first year fellow infectious disease at the University of South Florida. Thank you everyone for attending today. I'll be talking today on overview of tick-borne illnesses. I'll be focusing only on tick-borne illnesses that are present in the United States. So the overview, these are the tick-borne illnesses found on the CDC website that are endemic in the United States. Right now there's 10 of them. I'm also going to talk about one or two slides on tick paralysis because I had some curiosity on that. There are other tick-borne illnesses across the world, but it'll take too long to talk about those. So these are on the CDC website that I'm going to talk on. Most of the tick-borne illnesses share common vectors. The Ixodes scapularis is the most important one. Ixodes scapularis transmits Lyme disease, human granulocytic anaplasmosis, and babesiosis. And this is an important one to identify because this is the only time if you have a tick bite that you're going to give prophylaxis to someone because they could transmit Lyme disease to the patient. If you get bitten by any other ticks, you observe the patient and they don't need prophylactic medication. So it's important that you're able to identify the tick vectors. The Ixodes scapularis has the characteristic inferior part being brown. The Lone Star tick has the characteristic yellow to white dot in the mid-center. And the Lone Star tick transmits starry or southern tick-associated rash illness, human monocytic ehrlichiosis, and tularemia. Most of these ticks here are all hard ticks, and hard ticks mostly transmit disease, with the exception of this one here. This is a soft tick. This soft tick, you can tell, looks a little bit more spongy, a little soft. And this is the orthodontous tick, and it transmits tick-borne relapsing fever, or Borrelia hermsii. So I think the most important thing to be able to identify is this first tick right here, because this is the only time that you're ever going to give prophylactic medication to someone if they meet the criteria that I'm going to describe later on. So overview, most tick-borne illnesses are underreported because most of the disease that they cause is very asymptomatic. It could be fulminant disease in those who are immunocompromised. You should be able to identify the typical erythema migrans rash that's associated with Lyme disease. And eschars occur with rickettsiosis diseases and the characteristic rash with Rocky Mountain spotted fever. Increased number of cases in the summer months. The diagnosis is the same for all, with the exception of Lyme disease. I'll go into that. You use acute and convalescent serotiters. And the treatment's the same with all. You use doxycycline for all, with the exception of babesiosis and tularemia. So I'm going to spend most of the time talking about Lyme disease because it's the most common tick vector in the United States and throughout the world. It's transmitted. First cases were discovered in Lyme, Connecticut, and patients presented with a juvenile rheumatoid arthritis type picture, oligoarthritis, transmitted by the Ixodes scapularis on the East Coast, predominantly in the northeastern regions, and the Ixodes pacificus tick being this tick in the Pacific regions, like as its name implies, California or Oregon. It's important to know the prophylaxis. You give a single dose of doxycycline, 200 milligrams, if they fulfill all the criteria. The tick is identified as an adult or nymphal tick that's been attached for 36 hours, and it must have a good degree of engorgement. You can give prophylaxis if the tick was detached 72 hours ago, or if the local rate of infection is more than 20%. This local rate of infection only occurs in New England states, mid-Atlantic states, and some parts of Missouri and Wisconsin. So Rhode Island, Connecticut, those type of states. And this diagram here is from CID. The one all the way here on the left is the larval tick. The larval tick is an incompetent vector for Lyme disease, so it really doesn't play an important part as transmitting the spirochete. The ones that are important are the nymphal tick and the adult female tick. As you can see, there's a pretty big size discrepancy, about threefold. So nymphal ticks play the most important part in transmitting Lyme disease. So here, disease is based on degree of engorgement of the tick. If you have an unengorged tick, you don't have to give prophylaxis because that tick has not transmitted the spirochete into the blood. At 48 hours, figure A is the nymphal tick. You can see at 0 hours it's very small. It could be mistakenly for a piece of debris, dirt, a scab, so it could go unnoticed on the person. At 48 hours, you can see it's not even that big, but at 48 hours, that's enough time for it to transmit the spirochete. In comparison, the adult female tick in slide B, it's pretty big at 0 hours, so you'll notice it if this is attached on you. You can see at 48 hours, it's quite big, so you would notice it. So Ixodes ticks, they've done studies in prevalence of Lyme in nympho Ixodes scapularis ticks ranges from 20 to 35% in New England and Midwestern states. Like I said, larval ticks are rarely infected with Lyme disease. Unengorged ticks do not transmit the infection, and at least 36 hours of attachment is necessary for the spirochetes to migrate from the tick midgut into the salivary glands. So the diagnosis, the CDC recommends a two-tier approach. Usually use the ELISA, and equivocal or positive test results are followed up with the Western blot. Serodiagnosis is insensitive to the first 2 weeks of infection. If the symptoms have been going on for 4 weeks, in order for this patient to be positive, they must have IgG immunoblot specifically. With treatment, the titers do persist for long periods of time, so that's why you should use the clinical context. They've done studies, and even after 10 years, people have IgG seropositive even after treatment. Important things to remember: the IgM Western blot is considered seropositive if 2 or 3 bands are present. IgG Western blot is considered seropositive if 5 to 10 Western bands are present. Approximately half the population has reactivity with band number 41. So this is a characteristic erythema migrans rash. Erythema migrans rash usually has central clearing, usually erythematous around the edges, usually reaches a dimension of about 10 to 16 centimeters. Lyme disease is divided into 3 stages, stage 1 being the localized erythema migrans like rash, stage 2 being the disseminated infection, stage 3 being the persistent infection. If you don't treat Lyme disease, untreated, the spirochetes could go to different niches in the body, and that's why they cause stage 2 and 3 disease. They could go to basically any organ system. They go to the musculoskeletal, heart, they could actually go to the liver, so they could go to any niche in the body if untreated. So early Lyme disease is characterized by the erythema migrans rash. It happens 7 to 10 days after initial infection. The thigh, groin, axilla are the most common sites. It's important to distinguish this from hypersensitivity reactions, where hypersensitivity reactions are from tick saliva, and you could differentiate those because those expand rapidly but reach its dimensions in 2 to 3 days. So if you're unsure, you can mark them with a pen, and then if they don't grow after 2 to 3 days, you know it's a tick hypersensitivity reaction. They do not have any central clearing. They're more paretic, and they're more likely to respond from corticosteroids. EM occurs in about 75% of tick 75% of tick bites, and can be accompanied by non-specific symptoms: fatigue, headaches, fevers, and regional lymphadenopathy. So stage 2 can affect any organ system, mainly cardiac, musculoskeletal, could be liver, eye. You could have a rash that kind of develops a little bit more, and this is not related from multiple tick bites. It's related to hematologenous dissemination from the spirochetes. And these EM-like rashes are annular. They also have central clearing, but they're smaller, reach about 5 centimeters, and the borders can merge as well. After weeks to months, 15% of untreated patients develop neurological abnormalities and meningitis. The most common one that I saw reported was a cranial nerve 7 palsy. With the meningitis, you have a lymphocytic pleocytosis, and you could get positive intrathecal antibodies. And 5% of untreated patients, you get cardiac manifestations. The most common one being like fluctuating degrees of AV block. You also have complete heart block. These patients never present with any type of murmurs. And a common board question is that permanent pacemaker is not necessary. Even with a complete heart block, with treatment, the symptoms resolve in about a week. You can have migratory musculoskeletal pain, transient arthralgias, conjunctivitis as well. So stage 3 is a late manifestation. It happens many months after initial infection, so your serologies should always be positive. This usually manifests in arthritic pain, usually in oligoarthritis affecting the knee. The knee is very swollen. It does not represent like a septic arthritis type picture. If you do a synovial fluid arthrocentesis, the fluid will only show about 20 to 30,000 white blood cells. It will contain a lot of granulocytes. As I said, since it's a late manifestation, seropositivity will be present. You could get more diagnostic criteria by doing a positive PCR on the synovial fluid. Attacks of arthritis are relapsing remitting, and you also could have a late neurological Lyme disease with peripheral neuropathy. Again, the seropositive will be positive in the IgG immunoblot. The sensitivity of PCR is very low, so you should not use this to diagnose patients. Post-Lyme disease syndrome is kind of a poorly defined term that's easily confused with chronic fatigue syndrome and fibromyalgia. Really, they've done many studies, and there's no convincing evidence that these patients have active Borrelia burgdorferi infection after recommended treatment courses. So these patients present with pain, very vague symptoms, pain, neurocognitive fatigue symptoms, and they've done studies where they've treated these patients with 60 days of ceftriaxone, 60 days of doxycycline compared to placebo. When they do questionnaires, the two groups are similar, so they never recommended additional treatment courses after the first treatment course with post-Lyme disease or chronic Lyme disease. So the treatment courses, I think the important things to remember are stage 1. Use doxycycline. You could use amoxicillin or cefuroximine for 10 to 14 days. It's recommended that you don't use first-generation cephalosporins or macroglides. The important thing to remember from stage 2 that I saw emphasized a lot is if you have cranial nerve palsy and you don't have any CNF signs, if you don't have any increased headache, no photophobia, these patients with cranial nerve palsy, cranial nerve 7, could be unilateral or bilateral, just need PO doxycycline for 14 days. They don't need admission. They do not need a lumbar puncture if they have no signs of CNS involvement. If they have signs of CNS involvement, they need a lumbar puncture. They need ceftriaxone for 14 days. If they have a beta-lactam allergy, they could get IV doxycycline because of this good bioavailability. If they have carditis, they need 21 days of treatment. You initially could treat with IV. When their AV blocks or heart blocks resolve, you can transition to PO. So the most important thing to remember here is that I saw emphasized a lot is the cranial nerve palsy. Without any signs, you can treat with PO doxycycline. With stage 3, I think the most important thing to remember is this arthritis is the only time that you use retreatment. You treat initially with 28 days of doxycycline if they have no evidence of neurological involvement. If their arthritis minimally improves or stays the same, actually if it only minimally improves, you could use PO doxycycline again. If it stays the same or gets worse, our experts would recommend switching to IV ceftriaxone for additional 4-week course. So this is the only time that you would ever use retreatment courses. And it's recommended before you retreat the patient to wait at least 1 to 2 months before initiating treatment because you have slow resolution of the inflammation. You also have skin manifestations, but these are most commonly reported in Europe. The name for it is acrodermatitis chronica atropicans. It's a very late skin manifestation that happens more than 10 years out, and it's most common in Europe with the Borrelia azephili strain of the spirochete. It affects the extensor surfaces of the hands, feet. You have a bluish to red discoloration. The hands can look very doughy with edematous changes, and then they go to skin atrophy. These patients have very increased venous predominance, so it could lead to a false diagnosis of venous insufficiency, and they also have peripheral neuropathy. The diagnosis, since it's a very late manifestation, they'll have positive IgG seropositive on the immunoblot, and histologically they have histological changes as well. So you would treat just 21 days of doxycycline, but some people on like expert panels say if they have peripheral neuropathy, you could also give a 3-week course of ceftriaxone as well. So moving on to STAR, or Southern Tick-Associated Rash Illness. This was first discovered in the 1980s in Missouri, where physicians noticed an EM-like rash that was smaller than the one caused by Lyme disease, and patients had did not have a very severe, very mild course of Lyme disease illnesses. And it happened more in Missouri, so the Ixodes scapularis tick isn't very endemic in Missouri. So when they did more analysis, they found that it's transmitted by Borrelia lone starri and by the lone star tick being the vector. The lone star tick is an incompetent vector of Lyme disease. because the tick saliva in this tick actually kills Lyme disease. So the rash is typical of EM. It's described as an EM-like illness, mild flu-like symptoms, and actually you could have equivocal ELISA, but your Western blots will be negative. It's located mostly in the Midwest and Mid-Atlantic states, and they've done analysis of ticks, where a lot of them from Georgia and South Carolina. Most of them were Lone Star ticks, and very small proportion were Ixodes scapularis ticks. So the lesions can be single or multiple. The symptoms are non-specific. The clinical course is very mild compared to Lyme disease, and they've done studies where they compared patients from Missouri and people from New York who had Lyme disease, and comparatively, people with STARI are more likely to recall a tick bite, are more likely to be asymptomatic, more likely to have smaller lesions. The lesions are about 8 centimeters on average to 16 centimeters for Lyme disease, more likely to have central clearing, and more likely to recover rapidly after antibiotic treatment. They don't have any sequelae of long-term effects of carditis, musculoskeletal complaints after antibiotic treatment. So histologically, they're very different too. Lyme-like rashes have a predominant lymphocytic infiltrate compared to Lyme EM, which has abundance of plasma cells. There's no serological test to detect acute infection. Treatment's the same. You use a 10-day course of doxycycline. Because the Lone Star tick is the vector for human monocytic ehrlichiosis and STARI, you could have co-infection, but like I said, STARI is a very mild illness. So if you have a very severe illness with lab abnormalities, you should suspect ehrlichiosis co-infection. And theoretically, Tularemia has the same tick vector, but there have been no case reports of Tularemia being co-infected with STARI. And here you see the more central clearing, smaller lesions as well. And this disease was made famous in 2006 when President Bush acquired Lyme disease in Texas, and the Houston newspaper said that he had Lyme disease. But a couple days later, it's realized that you don't have Lyme disease in Texas. Correctly they said that he had southern tick-associated rash illness, and this was back in 2006. I don't know if he acquired it from this route or not. So Babesiosis, also transmitted by the Ixodes scapularis tick. Here again, like all tick-borne illnesses, ranges from asymptomatic infection to fulminant disease. More severe disease, as we learned, with asplenic patients, elderly patients, and immunocompromised patients. Because it's an intra-erythrocytic protozoan, it shares many clinical features similar to Lyme disease. It ranges from being an asymptomatic state to mild, moderate disease to severe disease. Asymptomatic, there are many people that have seropositivity for babesiosis that never have any type of clinical syndrome. And these are the asymptomatic characters, and really they only pose a threat when they donate blood. The American Red Cross, if you have any prior babesiosis infection, even with treatment, you cannot donate blood. And there's many case reports of transmission via of blood transfusions, and there's no high output test to detect this because it's just not cost effective. And then, even if you leukoreduce the blood or irradiate blood, the organism is still present. So there's 4 Babesia species that commonly affect human. I'm only going to talk about the first one, Babesia microcati, because this causes most of the disease in the United States. Babesia diversion is causing a lot of the disease in Europe. And in some reports, the clinical course is worse with this. So the first case is in Nantucket Island in 1969, endemic in areas of the New England states, New York, New Jersey, Rhode Island. Like I said, 3 illnesses: asymptomatic infection, mild to moderate disease, and severe disease. Severe disease being in asplenic patients. Presents as a viral illness with fevers, drenching sweats. Hemolytic anemia also being a hallmark. Fever is very common. So the definite diagnosis, as with all tick-borne illnesses, is a 4-fold increase between acute and convalescent titers. You also could use microscopic identification in the blood smear or amplified DNA using PCR. Lab abnormalities include a hemolytic anemia, increased reticulocyte, and thrombocytopenia. Parasitemia seldom exceeds 5%, but could be as high as 85% asplenic patients. The tetrad form, the Maltese cross, is pathognomonic of babesiosis. The treatment: mild to moderate disease, use atovaquone and zithromycin. Severe disease, clindamycin and quinine. If you have 10% parasitemia or significant hemolysis, renal, pulmonary, or hepatic compromise, that's an indication for partial or complete red cell transfusion. And then asymptomatic patients, you actually treat these patients if they have parasitemia that persists longer than 3 months. You would treat them with atovaquone and azithromycin. And even if you have a patient who's immunocompromised, you give them an initial treatment course. Immunocompromised patients, it's recommended that you monitor their blood smears Q1 month or Q2 months. And if they don't clear their blood with parasitemia in 3 months, that's another indication for retreatment. So these are the ring forms of the babesiosis. They could easily be confused with falciparum ring forms. And this is the pathognomonic Maltese cross, the 4 daughter cells, and the erythrocyte. So moving on to Ehrlichia, again, human granulocytic anaplasmosis. The vector is Ixodes scapularis, so it transmits that, babesiosis, and Lyme disease. So there's 3 different Ehrlichii: HME, human monocytic ehrlichiosis, human granulocytic anaplasmosis, and Ehrlichia ewingi, which is mostly a dog, affects animals, especially dogs. Here you have a picture of a monocyte being HME with the distinctive moruli in the host vacuoles and the cytoplasm. And this is a granulocyte neutrophil being HGA, and the moruli being present here. So the incubation period is 1 to 2 weeks. Most patients are febrile when they present. Very non-specific symptoms like all tick-borne illnesses. Myalgia, headache, and chills occur in 2/3 of cases. The rash is very rare in HGA. So if you have a case that you're suspecting HGA and you have a rash, you should suspect co-infection, because the rash is not usually seen in human granulocytic anaplasmosis. Conversely, it affects 36% of patients with ehrlichiosis. Ehrlichiosis, you have more neurological symptoms. Leukopenia, thrombocytopenia, and increased LFTs are common in both. There's no evidence of chronic symptoms as opposed to Lyme disease, and produces more severe infections than those who are immunocompromised. So Ehrlichia, again, the diagnosis of all tick-borne illnesses is a 4-fold increase between acute and convalescent titers. You could also use ELISA PCR, and presence of the intraleukocytic moruli. These are most commonly seen with HGA. 50% of the time you could see them with the moruli in anaplasmosis. In comparison with ehrlichiosis, you only see this 5% of the time. And the sensitivity is highest during the first week of infection. Treatment for both is, again, doxycycline. Doxycycline, they say you can't use in kids or pregnant women, but there have been many case reports of several pregnant women receiving rifampin for HGA with success. And again, preventive antibiotic therapy for none of the tick-borne illnesses, with the exception of Lyme disease, is recommended. So ehrlichiosis, endemic in these central states: Oklahoma, Missouri, Tennessee. Vector is the Lone Star tick that also transmits tularemia and stari. Many of the infections are asymptomatic, so is very underreported. Anaplasmosis is more frequently reported, but less severe illness. It's endemic wherever the Ixodes scapularis tick is endemic, so it basically affects wherever Lyme disease affects. And as with ehrlichiosis, many number of asymptomatic infections. Ehrlichia Ewing has only been 4 reported cases, and these have been from these following states here. Mostly a veterinary pathogen. So basically, just a comparison: anaplasmosis more common. Laboratory anomalies are shared by both. More likely to see moruli in the neutrophils with HGA. HME, it's more severe. Laboratory anomalies are shared by both, and you get CNS involvement, and a rash is more common. So moving on to relapsing fever. Again, this is the only soft tick that I mentioned, the Dorothyus soft tick, that is a tick vector for tick-borne relapsing fever, Borrelia hermsii. Relapsing fever is divided into tick vectors and louse vectors. The louse vector is the Borrelia recurrentis, that's transmitted by the human body louse, that also transmits transfever and epidemic typhus. The only one of these relapsing fevers that is found in the United States is Borrelia hermsii. Louse-borne relapsing fever is most commonly found in countries with social upheaval. It's sporadically transmitted into the United States, last time being 1871. You have relapsing episodes of fever, non-specific symptoms, headache, myalgia, chills, abdominal symptoms. And you get the relapsing fever because these Borrelia species are able to vary their surface antigens. They're able to have antigenic variation, leading to repeated episodes of spirochemia and stimulation of the host immune response, and repeated episodes of febrile episodes. You get the tick vector disease by obviously having a bite from the tick, and you get the louse-borne disease by either getting a bite or crushing the louse and then having it contact with your skin. So tick-borne relapsing fever is found throughout the world, endemic in the western states, and is not seen east of the Mississippi River. The tick vector is usually found at higher elevation. Vertical transmission is rare, so larvae are unlikely to be infectious. The high level of spirochemia is characteristic of fevers. If favorable, the organisms are microscopically undetectable. And mortality is worse with louse-borne relapsing fever, and this could be related to it happens in areas of famine, overcrowding, so the fatality rate is 5% of untreated patients. Again, we don't see louse-borne relapsing fever in the United States. We only see tick-borne relapsing fever. So differential diagnosis of bispecific fevers. Elias here covered a lot of them in his talk: yellow fever, dengue, Lassa fever, leptospirosis, and also the relapsing fevers caused by tick and louse-borne vectors. The diagnosis, again, acute and convalescent titers. You also detect the spirochetes in the blood during a febrile episode. This was a picture of high level of spirochemia in the blood, and she actually responded very well to doxycycline without any long-lasting effects. Treatment duration is 10 days, and with all spirochete illnesses, you get a Jerax-Herxheimer reaction with, rigors, hypotension, chills, worsening of the symptoms, but it's commonly reported in tick-borne relapsing fever 54% of the time. So the spotted fever group rickettsia. The rickettsia I always thought were confusing, but if you remember, rickettsia only could cause typhoidal disease, epidemic, endemic typhus, or spotted fever group rickettsia. There's 16 spotted fever group rickettsia, and I'm only covering the ones that are in the United States. The one that I think is big that I didn't cover is Rickettsia africare, where the hallmark is the eschar. You see this obviously in Africa, or people that went on a safari and returning to the United States. There's 4 of them, but last year a 5th one was identified in Northern California. So right now there's 5 spotted fever group rickettsia in the United States. We're all familiar with Rocky Mountain spotted fever being transmitted by the R. rickettsia, Rickettsia parkeri, Rickettsia fleas transmitted by cat fleas, and Rickettsia acari transmitted by the house mite. With all these spotted fever rickettsia, eschar is the hallmark, with the exception of Rocky Mountain spotted fever, where you have the characteristic rash, which I'll go into. Treatment and diagnosis are the same for all of them. The symptoms, clinical manifestations are almost all the same: fever, headache, and myalgias. So Rocky Mountain spotted fever, the Derman center tick, the Derman center dog tick affecting the eastern states, the wood tick affecting the western states. Half the cases in Oklahoma, Tennessee, Arkansas, and North Carolina. More fatal outcomes in the elderly and G6P deficiency, most commonly in the early spring or summer months. During the first 2 weeks, you have the classical triad of fever, headache, and rash in 70% of the patients. So this causes a vasculitis type picture. The organisms are able to multiply in small to medium-sized vessels, and it could lead to areas of microhemorrhage and increased vascular permeability. You could have, there have been case reports of gangrene, but that was way in the past where the case fatality was very high. The rash is typically described as being spotted, like you can see in these pictures, being a macular, then progressing to a macropapillary, then petechial rash. Blanching macules on the wrist, ankles with progression to the palms and soles, then spread centrally to the arms, legs, and trunk. Eschars are rare, so that's important to distinguish from the other spotted fever group rickettsia. So diagnosis, again, acute and convalescent titers, but these cannot distinguish from other spotted fever group rickettsia, and they're not detected 10 days after disease onset. You have anemia, thrombocytopenia, raised ALT, CK, bilirubin. Affect these mostly red states: Missouri, Arkansas, Oklahoma, North and South Carolina. Treatments with doxycycline. They say still the recommended treatment in pregnancy. You could use doxycycline, but you also use chloramphenicol, but that's not available in the United States, I don't think. So Rickettsia parkeri, with all the spotted fever group Rickettsia, eschars are the hallmark. It's transmitted by the Gulf Coast tick. First human case in 2004. Found during the Gulf Coast, Georgia, Mississippi, Texas, Alabama. The eschars are described as crusted, non-paretic, non-tender. Macropapillary or vesiculopapillary exanthem can involve the trunk and extremities. It's a milder illness than Rocky Mountain spotted fever. So here you could use a comparison. They're frequently confused, but if you remember, there's no eschar in Rocky Mountain spotted fever. The clinical course is a little bit more severe with Rocky Mountain spotted fever, and you get more abdominal complaints like nausea, vomiting as well. So this was a new spotted fever rickettsia discovered a year ago and reported in CID. It happens in Northern California. There's only been 4 reported cases, so it's very rare. And then again, the eschar is the hallmark. They diagnosed this by using acute convalescent titers that were seropositive for Rocky Mountain spotted fever, and they did more analysis of the ticks of this organism. They named it Rickettsia 364D. Affects only Northern California, and the full spectrum of illness is yet to be determined. So tularemia also could be transmitted via ticks. There are multiple ticks that can transmit tularemia, being the Lone Star tick, the dog, and wood tick. It's been brought back in the limelight because of bioterrorism. It's been added to the list of reported disease in 2000. It's a Category A agent of potential bioterrorism. There are 4 subspecies. However, Francilla tularemia is the most virulent and causes 70% of the infections. It can be acquired by tick bite, contact with infected animal tissues, ingestion of contaminated food or water, or an inhalation of contaminated aerosols. Incubation period is 7 days. Summer peak corresponds to a greater number of cases. Lymphadenopathy, fever, ulcer, eschars are the hallmarks. Most of the number of cases is from 1990 to 2000 on the CDC website. Most of the cases are, Missouri, Arkansas again. So we have 6 clinical manifestations of tularemia. The one that we're most familiar with is ulcer glandular tularemia. In fact, this is 70% of the cases. Usually the patients report recent animal handling, fever, single painful ulcerative lesion with central eschar, and lymphatic drainage that often suppurates is the hallmark. Lymph node enlargement can resemble a bubo of plague. You also have the glandular form, where you have lymphadenopathy without evident cutaneous lesion. And the other one I think is pretty important that we've had outbreaks of recently is the pneumonic form that usually affects the elderly. The last outbreak was in 2000 at Martha's Vineyard, where they were mowing grass and they had contact with dead animal carcasses. And this is important because as little as 10 organisms can transmit the disease and has the highest mortality. And that's why it's important if you have a case, you notify the lab personnel because it's a biosafety level 3 in the lab. Fever, dry cough, pleuritic chest pain. Pulmonary presentations are nausea infiltrates with pleural effusions that mimic those of Mycobacteria tuberculosis. And they also have a high ADA concentration in the pleural fluid. So these are pictures of ulceroglandular tularemia with the markative lymph node enlargement and lymph nodes that suppurate and kind of ooze out, and the eschar also being present. So again, the diagnosis, we had a question this last week. Again, is acute and convalescent titers a 4-fold increase between both, or a single acute titer of 1 to 160? Routine cultures of blood, lymph nodes, pleural fluid are almost always negative because this organism is very slow growing. If suspected, media should contain cysteine to support growth, and they also could be grown on chocolate agar as well, but that's something I found a lot of. Cysteine, you should ask the lab to add cysteine to the media if you suspect this. It's not transmitted human to human. Severe illness, you use streptomycin or gentamicin. doxycycline and ciprofloxacin can be used for mild illness, but are not recommended because of high degrees of relapse. The relapse has been reported almost to 15% for both. So streptomycin, gentamicin is treatment of choice. Tularemic meningitis, aminoglycoside with chloramphenicol. So tick paralysis is not transmitted like an infectious agent. It's toxin mediated. And I include this because I always wondered about it, had some curiosity. Really, there's no reported cases in the United States anymore. It's mostly an agent in the veterinary world. So it's caused by the tick bite, causes flaccid ascending paralysis. The vector is a Dermacentor wood tick, or the dog tick. 1912, a veterinary pathologist actually had 3 hypotheses of how this was transmitted in his sheep herds. Paralysis in these animals developed only in a female tick fed for approximately 1 week. The symptoms were toxin mediated because when he pulverized these ticks and injected them to other sheep, those sheep were fine. If the tick was not removed, progression from paralysis to death was rapid. Extremely rare. Most locations are located at the scalp, behind the ear, neck, and groin. Flaccid weakness begins in the lower extremities. Fever is almost universally absent. DTRs are diminished and can progress to respiratory failure if the tick is not removed. Cases are also in Australia as well. So here you have the Australian tick, and here you have the American tick. It happens by a decrease in acetylcholine release from the presynaptic areas. With the North American cases, if the tick's removed, there's improvement is within 24 hours. With Australian cases, the improvement takes a couple more days. And you can see here it's only transmitted from female ticks, and then one of the first slides I show you the size. So these ticks have to be very engorged with blood to transmit the disease. They have to be monstrous in size, so you will notice this if it was on you. And that's why it's not even reported anymore in the United States. So differential diagnosis of tick paralysis. You can see many of these differentials have a very costly workup, costly treatment course. But I think what's gratifying with tick paralysis, you just remove the tick, no more treatment is required. So prevention of tick illnesses. It's important to know what the endemic rates of Lyme disease or any tick diseases in your area. To use tick and insect repellents, to use permethrin that you can apply to the clothes and not to the skin, to use frequent tick checks if you're going camping with friends or family, to check if people have ticks on them. Proper removal of ticks. It's mentioned that you don't burn the ticks because the ticks could regurgitate into the blood and release the spirochete. To remove them just with tweezers and pull straight off. And light clothing to detect darker ticks. Being in Florida, I've been in Florida all my life, and I've only seen 1 tick in my life. And that was when I was working in the ER at the VA. This guy went camping up north, and he was asking me all these questions, and I still gave him doxycycline anyway. So I think it's important because ticks are very endemic in many parts of the United States, and it's important as ID physicians to know how to treat them. I know we could treat them broadly, give doxycycline, but I think a good physician treats because he knows what he's treating, not to treat empirically. Conclusions: no different vectors in endemic regions. Being able to distinguish an eschar, which could point to spotted fever, rickettsial illnesses. Be able to distinguish the characteristic erythema migrans rash versus a hypersensitive reaction. If more severe illness, suspect co-infection. And if I guess you don't know, you still can give doxycycline. So those are my references. Thank you.